Good afternoon. Good afternoon and welcome to the 119th Landon Lecture on Public Affairs. The Landon Lectures were started in 1966 by the late Governor Alf Landon and the late K-State President James McCain. The goal of the Landon Lectures is to bring the most prominent public figures to Kansas State University to discuss the pressing issues of the day. We are very pleased today to welcome Secretary Donna Shalala to the Landon podium to join 118 predecessors in bringing her thoughts and opinions on important public issues. Before introducing Secretary Shalala, I would like to introduce other members of the platform party. On my left, Jake Wooster, well, right there, a junior in agricultural economics and student body president. Thanks, Jake. Next to him, Dr. Mickey Ranson, professor of agronomy and president of the Kansas State University Faculty Senate. Mickey, thank you very much. On my right, you might notice that the chairman of the Landon Patrons, Edward Seaton, editor-in-chief and publisher of the Manhattan Mercury, is not with us today. Instead, he is serving as chairman of the Pulitzer Prize Selection Committee in New York. Dr. Charles Reagan is an associate to the president and chairman of the Landon Lecture Series. Dr. Shalala has served as secretary of the Department of Health and Human Services for over 7 years. This is the longest tenure in the history of that federal department. She joined the Clinton administration in January of 1993 and leads arguably one of the largest and most important of all federal government agencies. The Department of Health and Human Services is charged with protecting the health of all Americans and providing essential human services. The department's current fiscal budget is just shy of $400 billion. And she directs the work of over 60,000 federal civil servants. The Department of Health and Human Services administers a wide variety of programs, including medicine, Medicare, Medicaid, and federal welfare and children's programs. Under Secretary Shalala's leadership, Health and Human Services has enrolled more than 2 million children in the state children's health insurance program and has raised immunization rates to the highest levels in the history of America. In 1998, the Secretary launched Girl Power, a public education campaign showing 9 to 14-year-old girls the importance of sports and fitness. The Secretary has remained dedicated to preventing young people from using tobacco, alcohol, and illicit drugs. She has also crusaded for improved home access and medications to treat individuals with HIV and AIDS. Throughout her career, Secretary Shalala has been a scholar, a teacher, and a public administrator. Before being selected as Secretary of Health and Human Services, you might remember that Dr. Shalala was Chancellor of the University of Wisconsin in Madison from 1987 to 1993. In addition to her PhD from the Maxwell School of Citizenship and Public Affairs at Syracuse University, Secretary Shalala has received more than 24 honorary degrees and a whole host of other awards and honors. It is a special privilege for me to introduce the Landon Lecture 119th to Kansas State Secretary Donna Shalala. Donna?
Thank you very much, Mr. President. I admire your leadership. President Wayfold and I have many things in common. We not only led great land-grant institutions, but in addition to strengthening academics, we also turned around our athletic programs. And I admire leaders that take on both. I want to acknowledge Jack Wempe, the University Regent who's present, and of course thank your student body president and the president of the Faculty Senate for being here today. Charles Reagan, I called him to say that I would give the Landon Lecture, but I prevailed on him to let me do it after the election. I waited and waited and waited. Senator Howard Baker, who I'm greatly admired, talked about the characteristics of a good president in his own Landon lecture. He said that our candidates had to be honest and genuine and intelligent and know what they believe. He could have been describing his wife, Senator Nancy Kassebaum. During her distinguished career in the United States Senate, she was its leader in health care, but I always also admired her leadership on Africa. Some members of Congress always see the big picture, and Nancy Kassebaum and Howard Baker are two examples of that, and of course the extraordinary Bob Dole. I consider it a great honor to have worked with all of them, and in particular to have accepted Nancy's invitation to deliver this lecture. I am also, of course, a colleague of the famous Dan Glickman, and I say famous because most of us in the cabinet are very reluctant to spend any time on a podium with Dan Glickman because people are always throwing food at him. The last time I was with Secretary Glickman, we were at a nutrition summit, a perfectly harmless subject, a little boring even, unless you're in the field. And a woman came running up. I was standing right here. Secretary Glickman was at the podium. Bob Dole was right here, and Senator George McGovern, who's head of our food program, or the FAO representative in Rome, was on the other side of Bob Dole. And a woman ran up, and she said, "You meathead, Dan Glickman." And she threw what I thought was an apple pie at him, and he turned, of course, and it didn't completely hit him. And I was laughing so hard, and Dan Glickman was saying, "Why didn't you try to protect me?" But Glickman was very quick. He turns to Bob Dole and says, "Gee, Bob, I guess we're not in Kansas anymore." I'm very happy to be here at Kansas State. I did watch the football game last weekend. I loved it when the snow started. The great land-grant universities are really underappreciated in the East. My mother graduated from Ohio State, and of course I was lucky enough to lead the University of Wisconsin at Madison. Neither Kansas nor Wisconsin are very wealthy states, but the people of these states believe in education and invest their hard-earned dollars in their great state universities. Being here today, though, I'm reminded that at the turn of the last century, the historian Carl Becker wrote that the Kansas spirit is the American spirit, double distilled. The spirit that Becker was writing about, the Kansas spirit, is the spirit of rugged individualism, of restless imagination, of self-reliance and selflessness, of goodwill and good faith, of heart and of humor. It was the spirit that guided the Pony Express riders across the prairie. It was the spirit that sustained George Washington Carver when he homesteaded here in Ness County. It's also the spirit inherent in the state model of Kansas that tells us to the stars through difficulties. I can think of no one who better personifies this true American spirit than the person that we honor in this lecture series, Alf Landon. Alf Landon was quite unassuming. He demonstrated that spirit when he modestly described himself as an oil man who never made a million, a lawyer who never had a case, and a politician who carried only Maine and Vermont. Landon also demonstrated that spirit, in the words of another former Kansas governor, John Carlin, by not being a partisan. For example, while he undertook the daunting challenge of taking on Franklin Roosevelt in 1936, he also supported many of FDR's views on government. He ran under the campaign slogan of life, liberty, and Landon. He succeeded in getting his party to go along with many of the New Deal's social programs and to recognize the rights of labor unions and to support civil rights. And when the 1936 race was over, Alf Landon, who actually coined the phrase New Frontier, also demonstrated the true spirit of America by his good humor. In a frequently played snippet of a radio interview, he dryly observed that the most remarkable aspect of his 1936 defeat to Franklin Roosevelt was the completeness of it all. And he added that as Maine goes, so goes Vermont. I really like this one. He even went so far to give his grandchildren 2 ponies, and he named them Maine and Vermont. He once explained to an interviewer, "With me, politics was not a vocation, but an avocation." I believe that Alf Landon not only set an example, but he also set a benchmark for politicians who want to be both great and good. I can't help by wondering what Alf Landon would have made of our last 2 weeks of political excitement and uncertainty. The one thing I know for sure is that the pragmatic, good-humored, and fiercely independent Landon would have liked another pursuer of the impossible, the man from La Mancha. The main message of Don Quixote is that the most important thing is what we do after we decide. That is certainly true of America in the 21st century. Because I believe that no matter whom we elect as our president throughout this new century, regardless of their politics or parties, they must be guided by a vision that recognizes that the common good is the highest good. It is a vision that Alf Landon, who in the words of President Reagan was motivated by a genuine desire to help his fellow man, would have supported. And when it comes to health care, which is what I want to talk about today, it's a vision that requires that I think we meet 5 challenges. First, we've got to face the problem of the uninsured. Today, there are over 42 million Americans, including 10.5 million rural residents and 11 million children who have no health insurance. When this administration took office, our original goal was to insure all Americans at one time. That turned out to be politically unfeasible, not because the people of this country don't believe that everybody should have insurance. The people in America believe that everybody should have insurance. There simply is no consensus about how we get everybody insurance. Experience has taught us that the best way to achieve universal coverage is to get political agreement, step by step, on first the problem and second the solution. The weakness, I would argue, of our initial approach was that we had consensus on the problem, that there were too many Americans without health insurance. We simply moved ahead before we had consensus on the solution. So we have started to do this step by step. Let me give you some examples. Under the leadership of Senator Kassebaum and her colleague, Senator Kennedy, we began by making health care portable. Now in this country, if you change jobs or if you have a pre-existing condition, it doesn't mean that you lose your health coverage. In 1997, the President and Congress worked together for a second initiative to fashion a state's children's health insurance program. It's called S-CHIP. The program was designed for families who earn too much for Medicaid, too little to afford private health insurance, but just enough to fall through the cracks. Working in partnership with the states, today between 2 and 3 million American children, more than the entire population of the Cornflower State, now have good health insurance. Most recently, Congress and the President made it possible for millions of Americans with disabilities to join the workforce, to access the American dream without fear of losing their Medicaid or Medicare coverage. In other words, they can go to work and keep their government health care coverage. Similarly, children who age out of foster care can now keep their Medicaid coverage until they're 21. We've made some very important progress over the last 8 years, helping the uninsured get health care. For the first time in a decade, the number of Americans without health insurance has actually gone down. In 1999, 1.7 million more Americans had insurance than in the previous year. Still, as a nation, when it comes to health care for all, we still have miles to go to ensure that no one is left behind, or left out, or left on the sidelines, and to ensure that the poet had it right when he said, "America is a willingness of the heart." Of course, as we work to help the uninsured access health care, we have to work to eliminate ethnic and geographic health disparities. That, I believe, is our second challenge. The comedian Chris Rock once said, "Why should I pay taxes? I won't get the money until I'm 65. Meanwhile, the average black man in America dies at 54. Behind that joke lies a tragedy. Consider this. If you're an African American woman, you're over 20 times more likely to be diagnosed with AIDS than a white woman. If you're an American Indian, your rate of diabetes is 3 times the national average. If you're a Chinese American, you are 4 to 5 times more likely to have liver cancer. While in rural America, more than 20 million citizens have inadequate access to health care. 10% of all rural hospitals closed in the 1980s. And while only 25% of our nation's children live in rural areas, they account for 85% of all oral or dental diseases. We may have in this country the finest healthcare system in the world, but too many of our citizens enjoy less years in their lives and less health in their lives. And so when it comes to improving health, America can never move ahead if anyone is left behind. We've worked very hard to lift the shadow of health disparities that fall across minority communities, as well as to close the gaps between urban and rural areas. I have an Office of Rural Health Policy, specifically working to improve access to primary care and prevention services in rural America through a range of programs. For example, over the past decade, we've provided incentives to medical professionals to work in rural areas. We've supported relevant research on rural health services. We've awarded over $170 million in grant funding for demonstration projects that serve more than 300 rural communities, many of them in Kansas, to improve health care access for at least 2 million needy rural citizens. In addition, Nancy Kassebaum chairs the National Advisory Council on Rural Health, which recently issued a set of guidelines that help ensure that rural concerns are included in the new debates on reforming the Medicare program. These are significant accomplishments, but there's more that needs to be done. And while we're working to close the gaps between urban and rural, between minorities and whites, we also need to ensure that the highest quality health care is there for all Americans. And that's our third challenge. Americans know that our healthcare system has no equal. They know that we have some of the finest doctors and medical schools and science in the world. But they know it's not the best for everyone, everywhere, every day. Patients want to see a specialist whenever they need it. They want to know all of their medical options. They want to go to an emergency room when necessary. They want their medical records to be kept confidential. And that's why I believe we have to press for a strong, enforceable patient Bill of Rights, a Bill of Rights that will ensure access and choice and privacy and recourse against shoddy care for everyone. It's what healthcare needs, and it's, of course, what the patients want. Patients also want their medical privacy protected, and that's why I will follow the congressional directive this month and issue the very first federal privacy regulations to cover all healthcare needs. The guiding principle is that healthcare information can only be used for healthcare purposes. But ensuring that healthcare quality is much more than a patient's Bill of Rights or privacy regulations or any single measure. At its crux, quality is basically doing the right thing for the right person at the right time in the right way. 4 years ago, the Healthcare Quality Commission identified 3 overall problems in our healthcare system. First of all, there are simply too many errors being committed. The Institute of Medicine's report on medical errors, which was called To Err is Human, indicates that between 50,000 and 100,000 hospital patients in the United States annually die from medical errors. It's the 8th leading cause of death in this country. Additionally, there's a great deal of over and underutilization of the healthcare services. For instance, about 80,000 women get unnecessary hysterectomies every year. 180,000 Americans die because they didn't receive beta blockers after their first heart attack. And finally, as I discussed earlier, there's tremendous variation nationally between regions and local healthcare services that are offered in this country. If we want to ensure an America where the common good is the highest good, then we must ensure the highest quality health care. Similarly, we have to ensure that no American is denied access to the miracles of modern medicine. And that brings us to our fourth challenge, reforming our Medicare program for the elderly and disabled. The difference that Medicare has made in the lives of the elderly and disabled reminds me of a story by a famous author named Somerset Maugham. Maugham was asked to address a group on his 80th birthday. When the author was introduced, he began by saying, "Old age has many benefits." And then suddenly he stopped. He sipped some water. And finally he said, very slowly and very dryly, "Old age has many benefits. I'm just trying to think of some." He was, of course, trying to be funny. But when he made that remark 50 years ago, there was a sad ring of truth to his words. Old age meant poverty, it meant disability, and old age meant going without health insurance. In 1964, when the Medicare program was started, only 50% of seniors had any kind of insurance for hospital care. By improving access to health care, financial security, and overall quality of life, Medicare, which Alf Landon supported, changed all of that. I love telling the story of when Lyndon Johnson signed the bill. He actually went to Missouri, to Independence, Missouri, because he wanted to give the first Medicare cards to Bess and to Harry Truman, because Harry Truman, of course, had been a great supporter of getting health care to all Americans. And Johnson signed the bill, handed the first two cards to Bess and Harry Truman, and a young reporter came running up to him. And here's what the young reporter said. He said, "Thank you, Mr. President, on behalf of my mother." And Lyndon Johnson turned to that young man from the New York Times and said, "Young man, you should be thanking me on behalf of yourself." There are young people in this audience that don't think that Medicare or Social Security has anything to do with them. But it really has a lot to do with them. No American family could buy a home or send their kids to college if they had to pay the expense of going into the market and finding a health insurance plan for their elderly relatives, or they had to pay the equivalent of a Social Security check every month for their elderly relatives out of their own paycheck. Close your eyes for a minute. Think about what the bottom line is on your monthly paycheck, and think about the elderly relatives in your family, your grandmother, your aunts, people who wouldn't have anyone to support them other than that help from the Social Security check, and what kind of impact it has on their independence and on their dignity. Before we had Social Security and Medicare, families, of course, had to take on this responsibility. The entire structure of our society is built on the assumption that these two government programs, which bring dignity and independence to older Americans and protect them, do not come every month out of the paychecks of individual Americans. Sure, we all pay our Social Security and our Medicare, but much less than what we're spending in the system right now. It literally has changed the structure. I consider these programs direct subsidies to young people in America because they allow American families to do things that they wouldn't ordinarily be able to do, and allow American families to take care of their own young people. But a program designed for the 20th century needs to modernize for the 21st century. We have to improve the delivery of Medicare. We have to update its benefits. No one would create a Medicare program today without including the one benefit that has become an essential element of high-quality medicine, prescription drugs. Medications are as important to get today as hospital care was in 1965. In fact, medications keep people out of hospitals today. Medicare does not now cover these medications. Their prudent use can help older Americans not only avoid doctor visits, but very lengthy hospital and nursing home stays. But 13 million American seniors, including 50% of the seniors in rural America, have no prescription drug benefit. This is very much a rural issue in this country. We need a 21st century drug plan that is voluntary and accessible and affordable. that provides meaningful protection and bargaining power for our seniors, that offers competitive prices, that's easy to administer through the private sector. It has to maintain and strengthen Medicare's historic promise of providing the best health care available for American seniors. Our fifth and final challenge is to keep our science strong, but our ethics stronger. From the human genome to vaccine research to food safety, this century's blockbuster discoveries will come from America's scientific genius, from campuses like this one, Kansas State. But it will continue only if it receives support and assistance from our policymakers, from our Congress, and from future administrations. We've seen it recently in the case of genetically modified foods. Scientists have been improving plants by changing their genetic makeup for over a century. But today, as Dr. Jane Haney, who was once at Kansas, who was the FDA commissioner, said when she delivered the Enloe lecture here in March, a scientist can actually insert one or more genes into a plant and produce a new plant with entire new advantageous characteristics. For example, about a quarter of the corn planted in the United States last year carried a gene that produces a protein which is toxic to caterpillars and so reduces the need for chemicals. Besides reducing pesticides, we know that genetic modifications can enhance the nutritional value of food. And in the event that something unexpected does occur, the testing that developers generally conduct should identify a problem long before the product goes to market. But let me be perfectly clear. Our testing and evaluation so far has shown that in terms of food safety, the genetically engineered foods currently on the market are not significantly different from traditionally bred foods. And that's why we've continued to work closely with the great research institutions like Kansas State and with farmers around this country to help reap the benefits and minimize any risks that may arise from genetically modified foods. No group of Americans have a bigger stake in this debate than the farmers of the Midwest. We know we can count on them. They've led the way in reducing pesticides and expanding production to feed the world, to keep our food supply bountiful and safe. They have been strong supporters of American science. We also know that we can count on the students and the faculty and the researchers of Kansas State's outstanding College of Agriculture to help us find our way in this brave new world of biotechnology. And we know that we can count on Kansas State to continue to fulfill the mandate and the rich tradition of land-grant colleges by increasing and promoting knowledge of the agricultural sciences. But let me add just one word of caution as I finish. As much as I love and respect and support science, all of us have to recognize that our revolutions in research and technology and healthcare can raise serious ethical questions. Woody Allen once joked, "I was thrown out of college for cheating on a metaphysics exam. I looked into the soul of the boy next to me." Well, metaphysics is fine, but what we really need is some soul searching about science and medicine. For example, we must not have a 21st century where food science ignores food safety, where scientific breakthroughs widen the gap between the haves and the have-nots, where our genetic map is used to deny health insurance or jobs, or where our science gets ahead of our ethics and eclipses our fundamental sense of humanity, of fairness, and our values. Alf Landon once remarked, "It's a sin to throw a soft punch in politics." Similarly, I think he would have agreed that it would be a sin to tackle these 5 health challenges with half measures or half-hearted support. All lie at the very crux of a vision that celebrates the common good as the highest good. It's a vision, I believe, that confirms the greatness of this wonderful country. It's a vision that will prove not how good we are, but how good we can be. It's a vision for the 21st century that moves beyond politics and parties, and I think it's a vision that Alf Landon, that grand old man of the grand old party, would certainly support. Thank you very much.
Thank you, Donna. Did you answer a few questions?
Sure.
Great job. Great job. Thank you very much for doing such an excellent job in this 119th Landon lecture presentation. Secretary Shalala has indicated that she'd be willing to answer some questions, and as you know, we have microphones on your right and on your left. And so, do we have one over here?
No question?
Any questions?
Sure. For the radio audience, I'll repeat the question. The question is about the 60 Minutes story where parents believe that because their children got the measles rubella combination vaccine, that it may cause autism. The research to date, and lots of research in this area, finds no evidence that these combination vaccines or any vaccines causes autism. The department, through testimony and the National Institutes of Health, Food and Drug Administration has obviously looked at this issue too, has reported that to Congress. We have summarized the literature in this area, and we are going back and re-reviewing the literature so that we can reassure the American people based on our own reading of the research. And of course, research continues. There is no drug or vaccine in this country that is approved by the Food and Drug Administration in which individual doctors around the country don't have to report adverse incidents. And that's how the Food and Drug Administration tracks the effects, the long-term effects of drugs or vaccines or anything else that's administered in this country. That ongoing system, which is the best in the world, tells us a lot about the impact of these drugs after they're approved initially, after clinical trials. And I can assure you that we continue to look at all the drugs, medical devices, but there is no evidence to date of that fact. Any other question? Yes?
What do you recommend we do on a day-to-day basis as citizens to support some of the changes that you believe need to be made going forward?
The question was, what do I recommend that you do as citizens to do something about the changes that I recommend? The fundamental change, the core of what I was saying, is not simply that we need government to get more involved. We need to improve our programs, obviously, and I think we should update Medicare by including prescription drugs. But we need to get the healthcare system to work for everyone. There are too many variations in the healthcare system. I happen personally to believe, and maybe I just have become more conservative since I went to Washington. I know you think we all get more liberal when we go to Washington, but actually the opposite happens to you. You get more concerned about the spending of federal money. I think we spend an enormous amount of money in the healthcare system. We just don't get either people to the right place at the right time, too many people using emergency rooms instead of prevention activities. Communities need to organize, to look and see what healthcare is available in their community and to make sure that people don't fall between the cracks. And that requires education of families, of parents, of kids themselves. The most fundamental thing that all of us could do is to eat right, exercise, and not smoke. We'd have plenty of money for everybody. We'd probably have plenty of money to give every young person at Kansas State a free ride to college if we did that in this country. I would actually favor that. But the point is that there are lots of resources around, but very few people want to coordinate them, want to sit down as a community and say, look, we've got Medicare here, Medicaid here, we've got a community hospital, we've got some free clinics, and we need to we've got a veterans hospital, we need to put all these pieces together in a way so we know, and so that people know where they should go at the right time. And building that kind of network, so someone that walks into a clinic in a rural area is assured that if they need a specialist, they can get to that specialist in a seamless way. I think that takes community-based initiatives, not necessarily more federal money, but community-based initiatives to think through those flows of funds and how people in communities can get access to health care. Okay.
Secretary, in the United States, we spend anywhere between 12 and 14% of our gross domestic product on healthcare annually. And this far outmatches any other country, particularly those with comprehensive birth-to-death healthcare coverage like Canada to the north, who spends around 18% of their GDP. I was wondering if you might be able to shed some light on which aspect of the healthcare system is causing prices to be so far outmatched here in comparison to other countries. Is it doctors that cost more? Is it the research side? Is it insurance itself? You're not an economist, but I'm sure in your experience you might know.
Everything costs more in the United States of America when you get right down to it. We do more high-end medicine. The great academic health centers in this country, obviously, that we've invested in, we do more high-end medicine. Americans consume more drugs. But at the high end, we spend more money and have a more sophisticated system. And you know, the point is that every American wants the best quality medicine for themselves, but they don't necessarily want to pay for it. So we end up with a very expensive system with a lot of specialists in high-end medicine when we probably need, not to necessarily eliminate that, but to spend more money on the front end. I often talk about high tech and low tech. We need to spend more money on prevention, on primary care, on getting people to make sure that they get their shots at the right time, on getting young people not to smoke, on getting people to eat right. And if we did that, our high-end costs would be somewhat reduced. We'd also extend life, and obviously, and as we do that, I can't guarantee everybody that as we have more people in their 90s living into 100 that we won't introduce more complex diseases. But the fact is that a combination of more spending on the front end, more behavioral changes, taking our own responsibility for our families, combined with more active aging, organizing our lives and our society so that the seniors among us have opportunities to continue to be active, which is obviously more healthy behavior. That's my first recommendation. The second one is campaign finance reform. Part of the costs in health care, I am now at the point in this job where I answer everything when people ask me, why can't you fix that? Campaign finance reform. A doctor said to me at lunch, why can't you stop this advertising of prescription drugs that's driving the doctors crazy because it's pressuring them into giving more drugs than they really want to their patients? The answer is powerful interests got that law changed so that they can advertise. And the same thing with healthcare costs. There are 10 things that I could do with Medicare that would drive down costs, basically by getting better prices. We overpay for the things we purchase on behalf of people in Medicare, but it's the interests that make money over that overpaying and their powerful relationship with Congress that drives up the costs. So short little people like me, when you think of big government, just think of me, that have to stand on stools, don't get an opportunity to really show their stuff how they could drive down some costs in the healthcare system by getting more competitive pricing, by getting the government better prices. You could see that in the debate about pharmaceuticals. Basically, the companies are saying that unless we have large numbers of Americans that are prepared to pay sticker prices, they will not be able to do research. Now, they don't tell you that they've cut deals with every country in the world and given in to price controls. In Canada, in Mexico, where they've given away some of their margins, and then they're cost shifting onto Americans. I don't think that the government purchasing on behalf of seniors should pay a sticker price. I believe we should pay a fair price, but I don't think that we should offset some deals that they cut in Mexico and Canada, particularly not in the industrialized world. The underserved areas of the world, the areas of the world that have large numbers of poor people, I don't think any American would mind. But when wealthy countries get better deals than Americans do, I just think that's fundamentally unfair to American taxpayers, and that we need to do something about it without destroying the pharmaceutical industry that I think is critical both to our economy as well as to the future of the quality of health care in this United States. And somehow we have to find a bipartisan compromise to be fair, not just to seniors, but to taxpayers that end up paying these bills.
Here's a question over here.
Okay.
How do you see the interface between FDA and USDA working in the future, particularly with relevance to areas like new antibiotic development and approval?
Yeah. This is a very good question. It's not only FDA, the Food and Drug Administration, and USDA, but it's also EPA, the Environmental Protection Administration. And under this administration, we've tried to put together systems in which there have been very careful coordination. We even now have a food council, a research food council with a professor from Kansas State, if I remember correctly, heading it, that helps us to coordinate some of our food safety issues in this country. We need very careful coordination between these agencies to ensure that vaccine development, that what we do with both animals and foods for those animals, as well as foods for the American people, are absolutely safe, and that we continue these scientific investments. We've gotten more cooperation, more seamlessness in this administration. There's less tension between the Food and Drug Administration and the Centers for Disease Control and the EPA in this administration and the Agriculture Department than they have been before. And that actually is a characteristic of the administration. We tend to work pretty well across lines. And even when there is tension, the principals, the secretaries, get together and work through these issues. It's important for those in the agricultural business, for the scientists, for the people that consume our products, that they know that the government agencies aren't stepping all over each other in the process of trying to make safety decisions.
Over here.
Yes, Dr. Shalala, thank you very much for all your leadership. And your comment earlier about communities coming together and coordinating their resources. I'm Carolyn Ernest, and I'm from Wichita, Kansas, and right now I have the pleasure of being the chair of the Board of Health at Sedgwick County. I also participated with a small foundation which brought Project Access to Wichita, Kansas. And it was very difficult at first, but when you get everyone in one room in a community and they have to face each other, and then you present something such as a Project Access that's working in Asheville, and they look within themselves and say, why can't we do that? And it works. It's a grassroots, but it works. What I'm excited about is it and programs similar to it are the sample of what we need to do between public health and private health, bringing them together so they face each other, but also so that they learn from each other. Like in private health, we need to learn, probably in private health, what public health has learned, and that's looking at populations of patients with disease and creating systems of care around those populations of cardiac or pulmonology or whatever. And there's a stubbornness to look outside of ourselves for the solutions, and I believe public health can show private health, and actually in partnership such as Project Access and some of the other organizations in the community.
I agree with that, and I think you said it better than I could about how communities have to come together. But, you know, medicine and public health have been sort of two trains running along, and the need for them to come together and start talking, but public health needs to be changed too. It got too institutionalized. When I came to the department, there were serious grown-up people being paid for with your tax dollars that actually believed that American teenager behavior could be changed with a public health brochure. Now, I never met a teenager that read a public health brochure. I certainly didn't. And so we took them to MTV. I even in a weakened moment, did a Milk Mustache ad. We talked with a lot of help from American baseball. We broke the connection between chewing tobacco and American baseball, but we got the soap operas to start describing diseases accurately. More people learned about how AIDS was transmitted by watching soap operas in the United States. We went to media and integrated public health messages. But public health people also have to get out on the streets. We need to coax people into the healthcare system. We need to find ways to convince young Americans that they shouldn't start smoking, that alcohol abuse really will affect their lives in the short term as well as in the long term. And all of these things, are not easy to do. I was at a high school the other day, and I asked the young people what we could do to help them avoid smoking and alcohol and other kinds of risky behavior. And a young woman stood up and she said, make me strong inside. And in the end, that's the most fundamental public health. It's helping young people to negotiate through adolescence. Is there anyone here that wants to go through adolescence again? Are there any volunteers here? The answer is no. But strengthening our young people is obviously fundamentally the responsibility of their parents, but also the rest of us to reinforce that. And we'll have a far healthier society. But I congratulate all of you in Wichita for your project.
So we'll have a couple more questions.
Okay.
Let's have one right here.
Thank you for being here, Secretary. We've been talking a lot about healthcare lately, and people have been talking about universal coverage, but missing from the public debate seems to be any mention of the one system that the most people seem to agree would be a way of achieving universal coverage in our country, and that is the single-payer system. I was also glad to hear you talk about campaign finance reform and the political, you said it was politically infeasible, the problems of big corporations having too much influence over our government.
Well, small corporations too. Some of these companies are smaller.
Well, I was wondering if you would discuss some of the
Single payer?
what you think about the single-payer system and why you think it isn't getting any discussion.
Well, one of the points I made, and sometimes my staff tells me this point is too subtle. I actually think it's a sledgehammer, is that in the original Clinton health care plan, we actually diagnosed the problem correctly. There were too many Americans without health insurance. And all of our polls showed that Americans understood that they thought it was terrible, that they thought we should get everybody health insurance. But we then designed the solution. But there was no consensus on the solution. Americans couldn't agree that they wanted to move away from an employer-based system. For many of them, they were union workers. They had negotiated benefits for years, giving up some income. So they weren't about to give up that system. They were worried about how the Clinton plan, which was very complex, would affect what they already had. They were worried about a government-run system. Those single payers, the single-payer systems around the world are pretty straightforward. I don't necessarily favor a single-payer system. Unlike England, who had a health care system that was destroyed after World War II, in which they went to a government-run system, we have always had a public-private system. I don't think there's anything particularly wrong with it, a public-private system, as long as we can fill in the gaps. But filling in the gaps require that we reach some political agreement about what the gaps are and how to fill them in. And as long as we can make it highly efficient, of the highest quality, and not spend more money than we should. It's more complex to have a public and a private system merged together, but increasingly the government and the private sector, large corporations in this country, who are worried about their bottom line on healthcare, are coming together to try to agree on quality measures, on outcome measures, rather than regulating the front end, trying to figure out whether we can actually measure quality and pay accordingly, trying to reduce the number of people that go to the high end of healthcare costs because we haven't done enough on the low end, on the primary care and on the prevention side. And there are lots of things we could do. Look, when we started out the first campaign in 1992, who was talking about HMOs? Who was talking about prescription drugs? Not much. I mean, it wasn't the center of this. It's been the center of the last debate. HMOs, the Patient Bill of Rights, prescription drugs, but they're really proxies for general unhappiness with some things that seem to be going wrong in the healthcare system, and particularly by the people that provide healthcare, not having enough time to talk to their patients, being pressed by the reimbursement system, and I just have enough faith in this country. And when I say that, I'm not talking about government, that we can sort this out. Some of the things we have to do at the community level. Some of the things we have to do at the individual level. I talked about prevention and how we had to strengthen our young people and our families about risky behavior. And some of the things we've got to define pretty narrowly for a government role. And fundamental to all of this, I do not believe the government should be overpaying for things that it purchases, for example. And I do think that when the government provides a program, because the private sector won't, health care for the elderly, it ought to be of the highest quality. Thank you.
Okay.
Thank you very much. Thank you.
Thank you.